Atrial fibrillation as the learning objective for the high yield material. I am Dr. Asifullah from KMU Institute of Medical Sciences in Kohat, and this is CVS 2 module atrial fibrillation topic. The pathophysiology is like a chain reaction, and unfortunately, it is one of the most common sustained arrhythmia. The electrical chaos is rapid chaotic atrial activity, 350 to 600 per minute. Mechanical failure is the loss of organized atrial contraction, atrial kick, and ventricular disruption is irregular ventricular response. That obviously will lead to low cardiac output, which will lead to heart failure, hospitalization, and mortality, increased risk of thromboembolism up to 5-fold risk of ischemic stroke and dementia in these patients. The etiology: systematic and surgical, hypertension, electrolyte imbalances, low potassium and magnesium, surgery, sepsis and stress, and thyrotoxicosis. Cardiac architecture issues like heart failure and cardiomyopathy, coronary artery disease, myocardial infarction, mitral stenosis, and other valvular heart diseases like mitral regurgitation. Congenital cardiac issues are lung disorders like COPD, pneumonia, pulmonary embolism, obesity with obstructive sleep apnea, alcohol, holiday heart, and excess stimulants, aging, and family history. The clinical presentation is highly variable. In the chest, palpitation and angina; in the brain and CNS, fatigue, dizziness, syncope, although rare, they may occur. Lungs may be there are dyspnea in patient, and critical caveat is that there may be no symptom at all. The irregular R2R interval with fibrillatory waves and no formed P waves is AF until proven otherwise. Irregular rhythm is the hallmark. The visibility of P waves is not there, although fibrillatory F waves are present, and usually narrow QRS with variable ventricular rate. It may be fast or slow. The comprehensive diagnostic track establishes baseline risk like anticoagulation, assess chest VAS score with bleeding risk, full ECG with or without Holter monitoring, blood levels of hemoglobin and others, complete blood count with urea electrolytes and magnesium levels, thyroid status through TSH, very common association, structural problems through echocardiography in heart, ischemia if suspected, and chest X-ray with or without sleep study if obstructive sleep apnea is suspected. If the patient is unstable, for example, hypertension, shock, pulmonary edema, ongoing ischemia, chest pain, shortness of breath, and then patient is unstable and immediate DC cardioversion is required, synchronized shock. And if not unstable, rate control or rhythm control depending upon the strategy for individual patients. Rate control is when you keep the ventricular rate slow in reaction to atrial fibrillation. It is done in older and sedentary asymptomatic individual, and first line for most of the patients, and AV nodal blocking drugs are the key interventions in rate control strategy. In the rhythm control, sinus rhythm is restored in young, active, highly symptomatic, selected patients with cardioversion, antiarrhythmics, and catheter ablation. Beta blockers are the first line. Metoprolol, bisoprolol. Caveat is that carvedilol is preferred if heart failure with reduced ejection fraction is present. However, bisoprolol is also there in contention with the carvedilol. Calcium channel blockers, diltiazem, verapamil, excellent for preserved ejection fraction and avoid entirely in heart failure with reduced ejection fraction. And digoxin, the niche use is sedentary patients' heart failure or as an add-on therapy in patients with atrial fibrillation. Target metrics are resting heart rate less than 110 for lenient and less than 80 if persistent symptoms despite lenient control. Rhythm control prioritizes restoring cardiovascular outcome in specific patients. First episode of strong patient preference, young active patient, LV dysfunction or heart failure, recurrent symptoms, younger age, and early if less than 1 year in duration. The 48 hours mark for onset of AF. If it is 48 hours, stop for transesophageal echo to exclude aerial thrombus or LA appendage thrombus, or anticoagulate for more than or equal to 3 weeks prior and then proceed to cardioversion. And if it is less than 48 hours, electrical or pharmacological chemical cardioversion is done. Mandatory universal protocol is anticoagulation for more than or equal to 4 weeks post cardioversion regardless of whatever strategy is done. Antiarrhythmic pharmacological maintenance requires strict structural vetting. Sutalol, standard maintenance therapy. Flecainide, only if no structural heart disease, can be used as pill in the pocket for paroxysmal AFib, amiodarone. Highest efficacy warning. It requires strict monitoring of thyroid, liver, lung, and eyes. LFTs, TFTs, BFTs, and retinal examination. And propafenone can be used in structurally normal hearts only. Catheter ablation will create an electrical firewall around the pulmonary vein and may correct the issue of atrial fibrillation for long-term rhythm control. It is used in symptomatic paroxysmal AF or persistent AF after failed drugs. Maybe first line in selected people. The HFrEF advantage is it improves ejection fraction, reduces heart failure admissions, and may reduce mortality. CHED-VAS score is CHF, hypertension, age above or equal to 75. Diabetes, stroke, TIA, or systemic embolism, vascular disease, age 65 to 74, and gender was later on excluded, but may be included as female gender. Everything scores 1 except for stroke, TIA, systemic embolism, and age more than 75 are equal. Men more than or equal to 2 points, start DOAC, women more than or equal to 3 points, start DOAC, direct oral anticoagulant. High Has-Bled may need to evaluate anticoagulation, and Has-Bled identifies modifiable risk factors and flags the need for closer follow-up. It doesn't override CHED-VAS mandate, so you measure whether there is stroke prevention important or bleeding risk reduction important. DOACs are the universal preference with narrow mechanical exceptions. So apixaban has lowest major bleeding risk. Rivaroxaban, dabigatran, and apixaban may be used. Warfarin is strictly reserved for mechanical prosthetic valves and moderate to severe rheumatic mitral stenosis. Warfarin is the good choice rather than apixaban. Heart stops and contraindications: never use verapamil or diazepam in HFrEF. Never use flecainide or propafenone in structural heart. Never use DOACs in mechanical prosthetic valves and severe mitral stenosis. Never use aspirin routinely for stroke prevention in AF. Diagnosis of AF: irregular rhythm, no P waves, fibrillatory wave is AF. Unstable AF, immediate DC version. Default action: stable AF defaults to rate control. Beta blockers preferred. The 48-hour rule: above 48-hour TOE or 3 weeks of anticoagulation before cardioversion. Ablation is pulmonary vein isolation for effective long-term rhythm control, and stroke is the main danger. DOACs like apixaban are the choice. Warfarin is for mechanical valve or rheumatic mitral stenosis. Continue anticoagulation more than or equal to 4 weeks post cardioversion.